The subclavian approach to central venous cannulation has several advantages compared to accessing the jugular on the neck, and clinical circumstances will sometimes require it. It's a safe procedure if proper technique is used, but be vigilant of complications such as arterial puncture or pneumothorax. We generally prefer a right-sided approach, as this allows for visualization of the guide wire reaching the superior vena cava during the procedure, but if a left-sided approach is needed, this is how we perform it. Be sure to have a comfortable working position with the ultrasound machine within your line of sight. Perform a pre-procedural scan and begin by identifying the clavicle and imagine the midline of the body. The probe should be placed at a 90-degree angle to this line rather than parallel to the clavicle. Now tilt the transducer in a cranial direction. At this location, you should see two vessels, a vein and an artery. The pulsating artery will usually be located deeper and more cranially, but in close proximity to the vein, which can be further identified by its propensity to collapse during the respiratory cycle or expand when the patient performs a Valsalva maneuver or is placed in the Trendelenburg position with lowered head and raised lower extremities. You need to be absolutely positive that you've identified both the artery and the vein. If this proves difficult, try a bit more lateral. Color Doppler may be useful, but is generally not required. If the vein is very small or located deep within the tissue, it might be a good idea to consider another location for central venous access. Prep the area with disinfectant according to your local guidelines, and make sure that the area is large and includes the neck, as we'll be scanning this area to make sure that the guide wire hasn't deviated in a cranial direction. Keep this in mind while placing the drapes. Once again, identify the artery and the vein and move the probe medially to the point where the vein dives in under the clavicle, which you see as a shadow to the right in the ultrasound picture. Start injecting local anesthetic a few centimeters lateral to the edge of the probe. Subcutaneous injection anesthetizes the area where the suture goes that holds the catheter in place. Next, inject along the planned path towards the vein and try to keep the needle in plane in order to visualize it and stop just before you puncture the vessel. There's no need to aspirate as you go along, as the volume of local anesthetic is too small to be toxic even if injected intravasally. Now keep the probe as still as possible so you don't lose the view of the vein and the path that you've now anesthetized. Puncture the skin just lateral to the probe. Note how we firmly lodged an empty 2 milliliter syringe in the cannula. With a firm grip around the syringe which acts as an improvised handle and an index finger guiding the cannula, it's much easier to achieve a perfect in-plane view. And remember that it's unsafe to advance the needle unless you can see the entire length of it. Now this is the point where we see that we puncture the vein, which we confirm by aspiration of dark venous blood. Hold the cannula steady and quickly cover the bore as you remove the syringe. Insert at least 25 centimeters of the guide wire, but don't remove the cannula just yet, as it facilitates verifying that the guide wire is actually in the vein. When you visualize the artery, it follows that it should not be cannulated or have a guide wire in it. The next step is to move the probe to the neck to check that the guide wire hasn't deviated cranially up into the jugular vein. If present, you see a small, bright dot in the vessel. If that is the case, retract and reposition it under ultrasound guidance. Scan the jugular vein in a caudal direction and visualize the junction with the subclavian vein. At this point, you should see the guide wire descend in the direction of the superior vena cava if it's been placed correctly. Proceed with the cannulation in the usual manner. An average-sized adult will usually require a 20 centimeter catheter. You can further confirm the venous placement by observing the height of the blood column and the non-pulsatile flow. A post-procedural X-ray is pertinent in order to verify the tip location and exclude common complications, though note that ultrasound is actually better at detecting pneumothorax.